What advice do you have for those who don't have a link to a VA system in terms of negotiating protected time and research time and acquisition of funding?
So if you don't have access to the VA, what you can do is, depending on how big your institution is, a lot of guys up here have very large, right? I think Chris, you were at Ohio Health. Your reach is probably very large, right? So say, for instance, you wanted to do some research, their informatics will be able to extract all the data, and they're going to have a very good number of patients. So I would say get together with your informatics, at least like say if I want to do something on the Duke side system, we have Duke LifePoint hospitals. It would be a matter of getting my informatics person to extract all that data, and at least you could do something regionally. You can also, if you have the funding, get CMS data. You can actually purchase things like that, and then you can run analyses through there. There's always the NCDR, but that's less clinical, clinical research, more registry. They are doing some studies, but those would be good places to start.
I have a follow-up question for you as well, Dr. Gutierrez. I enjoyed your talk about establishing mentorship relationships, and maybe you could talk a little bit about sort of that first date. You talked about aligning interests and making sure that mentor-mentee relationship is going to work for both parties. How does one prepare for that sort of first meeting, that first discussion? How do you do that well?
So I was fortunate that I always had my primary mentor right now is Sunil Rao, and the person that introduced me to him was Arman Ascari, who was a mentor when I was a resident. If you don't have somebody that can introduce you already, because they probably already know you and know if you're going to click, my recommendation is you want to read at least their most recent 4 or 5 articles and say, hey, you're in this area, you've done this, X, Y, and Z. You may also, the other thing is to talk to their previous mentees and be like, hey, what do you think about this person? That way you at least have some ammunition, because it's like I hate to say it, it's like a first date. They're judging you just like you're judging them. Mm-hmm. And first impressions are very hard to get over. So you want to go ahead and prepare as much as possible.
Absolutely.
There's an audience question.
Yeah, I had a question from for Dr. Beckman regarding surveillance and follow-up. And I wanted to know your thoughts about cost effectiveness. And should we tailor our follow-up to, let's say, the intervention? For example, if a patient had a very extensive intervention, maybe they need to have more intense follow-up rather than, somebody that had a very minor, angioplasty or DCB or short lesion. Do they also need the same intensity that you showed on your slide related to cost effectiveness, but also the patient's efficiency of being able to come back for all these follow-ups?
No, I think that's a really important point, and we don't have a large enough data set for me to tell you that it's cost effective to do it. Although I would say if you can prevent secondary procedures, preventing one, say, surgery or one replacement of all your endovascular hardware, that probably pays for a lot of patients worth of surveillance. The other thing I'll say is that we will have this data when the BEST CLI trial is over, because we're going to have thousands of people who've gotten surveillance at their institutions if they do that. And so we'll know if more intense surveillance is going to be beneficial. I think one of the keys to the SVS suggestion is that Doppler ultrasound may or may not be necessary after the first 3 months, right? At that point, what we're really doing is mostly in-office stuff that you can do to follow up these patients. And so I think that it's going to be a combination of things, and I can't give you surveillance cost effectiveness because nobody's done a large enough study for us to know.
Josh, I have a question for you, which is if we're doing for CLI and InfraPop vessel, the pushback would be to say the wound's healed. I don't really care if the vessel goes down. The wound's healed. I want to really intensify the medical therapy because the patient's going to die of a heart attack or stroke. Let's really focus on that. I'm not going to go back in and reopen that PT if it's not causing a problem versus an upstream lesion, which might be a bigger issue because it provides bigger inflow. Should we be looking at this from a different vascular bed perspective, or should we, be aggressive and go after that PT again?
Yeah, so I think a lot of this depends on the patient themselves. So if you are able to heal a wound, say that your wound was a 1 centimeter ulcer in the ball of the foot or the toes, and they healed, can they still walk? I mean, actually what our real goal is restoration of normal ambulation. And so if that vessel is necessary for normal ambulation, then yeah, I would do a full surveillance program. If, on the other hand, this is not someone who's ever going to do much more than leave the house, because of other comorbidities, for example, then no, I probably wouldn't do more surveillance. And I agree there's going to have to be some individualization, but I think it's the bigger picture is if the goal is restoration of ambulation, you have to make sure that whatever you've done to restore ambulation stays in effect. That's the way I would look at it, I guess.
Tony, I want to just make a comment. Loved your talk and your personal experience. I think that is why this talk is so pertinent. I want to add two things. One is the issue of milestones. A mentor mentees has many mentees. I think it's very important for the mentee to have align milestone expectations with the mentor. I think that always helps. The second question is very pertinent, is regarding research opportunities and protected time. So I can tell you that the best way protected times are granted at most institutions are either on the basis of available funding or the promise of funding. So if there is no available funding, the request for a protected time should be supported with a business plan, like milestone-based approach. And I think that is probably my best advice I can give to anyone who is seeking protected time. I'm sure my colleagues will agree across the institutions and types of institutions.
One more question before we move on. We do have a little bit of extra time, as we will be skipping one session. But Phil, so I had a question about identifying regions of poor access despite insurance. So how do we take that to the next level? What's done at from a legal perspective and from a policy advocacy standpoint? Where do we take the data once we find out?
Yeah, thanks. I think that's a spot-on question, and you're right. We found that in the data that I showed, last in a recent project, that even though these patients have Medicare, they have Medicaid, they're sort of plugged into the system, if you will. Their results with CLI treatment were worse. So clearly something isn't getting to where it needs to be. Whether that's better community-based resources, whether that's advocacy for further home-based therapies that can try to better identify which patients will benefit from those interventions. I think we have to begin to develop those processes, and as Josh just alluded to, much of it, I think, will be outside the scope of what we do in the cath lab or in the operating room. Much of it will be patient, evaluations of, well, what are your goals? Do you want to, one prior speaker this morning, do you want to just sit in the chair? If that's the case, maybe that's not the patient that gets revascularization. So, broadening our field to involve experts outside of what we typically use to make a treatment decision, I think, is what's necessary.